Excellent. And welcome everyone for July's LSL ultra wide field teaching session. Today is going to be a workshop on and a case discussion. So over to Simon. Thank you.
Thank you very much again, and welcome to you all in this rather warm summer it's now turned into. So that's great news. Tonight is a little bit different. It's not going to be a straightforward lecture. This is a kind of version of a workshop. Hopefully, most of you have received a set of questions. If you haven't received the questions by email, what you really need tonight is a piece of paper and a pen. And I'm going to be asking you lots of questions about some cases we're going to be looking at. And I want you to look at what you think you're looking at and how you would treat it and what you would do with it. And then how you're going to talk to the patient about it, if you're going to refer it, what you're going to do there, and also what you're going to record on the patient's record card. So this is called the dilemma for a very simple reason. You've now got an image and you've got a dilemma. What are you going to do about it? And so tonight is all about building that confidence. And what I want you to do afterwards is to, within your sort of reflective thinking and learning, don't just put your answers in a drawer or the shredder or something like that. I want you to go away and look at those in the light of what you've put down and what I've talked about tonight, and just see where you differ and where you think you could improve, where you think you could improve your understanding, and work through from there. So it's a very much sort of kickstart you into other processes, because tonight is all about building confidence in decision making. So as I say here, this is about making sensible clinical decisions. So whilst, if you haven't got any paper or pen, whilst we're doing, you go and hunt that down. Um, I'm just going to go through some little sort of hopefully pearls of wisdom here. So what do I do next? You've got an image there, and what on earth do I do next? Well, remember the overarching thing in all of this. You've got a duty of care to the patient. So whatever you're going to do, you're going to need to do what's necessary to protect them. But at the same time, you don't want to unnecessarily worry them, because that's almost as bad as doing nothing in a lot of cases. But of course, you as an individual don't want to fall foul of any GOC or sort of college guidelines or anything like that. But also, in order to get the right answer, you don't want to start blocking up your appointment books with follow-up visits that really just sort of allow you to say, well, at least I was doing the right thing. Because even if you still make the wrong decision at the end of that, it's still a wrong decision. So we're trying not to block the book up, but we're trying not to do anything wrong either. So really, when you're recording things in a patient record card, it's so important to put your thinking down, your reasonings and your conclusions down within that record card somewhere or other, so that if I came in and questioned you as to why you've done something, there is your working. I always say it's a bit like a maths exam, where if you say 5 + 5 = 9, you get nothing for that. But if you show how you arrived at 9 instead of the right answer, you'll get some credit for your thinking behind it. So this is what we're doing here. But remember, when we're dealing with things like ultra wide field imaging, we're on that cutting edge, as I've said before. We're doing things that an awful lot of people won't do. So your judgment, you will be judged against the normal standard actions of what the average optometrist would do in your position. So if you're getting it right from your enhanced position, you're way ahead of the game anyway. So tonight's all about trying to have some confidence there. But I mentioned there about bringing a patient back unnecessarily. Monitoring a patient for no good reason, just for the sake of saying, well, I saw them 6 times, and that's not really good practice, because it often causes them unnecessary worry. And as I think I might have said to you before, your patients, unsurprisingly, don't want you to find anything wrong with them. What they want to hear is everything's okay, not that there's a problem. And this is a nice little example here. If you consider somebody sees a lump on an X-ray, and they do all the appropriate tests at the time of discovery, and the consultant reviews the findings and weighs up the probabilities of whether this is something nasty or not. He decides the probability is low and the patient isn't at any immediate risk. Well, he's got two ways of telling this to the patient. He can either say, well, it's probably nothing, But what we'll do is we'll monitor it frequently just in case it changes. Well, that's one way of talking to them. But what the patient actually hears there is the consultant saying, well, it could actually be a malignancy. You've got cancer. And that's how the patient interprets it. And they panic and they're really unhappy. Whereas scenario two, they could say, well, we've looked at your scans. You've got some normal variations. Everybody has this sort of variation, but they don't point to anything sinister. So we don't need to do any more monitoring. That's the really good news. What we'll do is recall you like we normally would for your routine eye test. What the patient hears that time is everything's normal. The patient's reassured. So it's the way you pass those findings over to the patient. So, as I say, more testing just for the sake of it often equates to more patient worry. So, again, before we start looking at these cases tonight, I just wanted to take you through some of the things that the GOC sort of always pick up on. So, and they're obvious ones, really. Record keeping deficiencies. If any of you read the professional magazines and look at the GOC sort of case outcomes, so often it's record keeping deficiencies, failing to record certain aspects of examination, not being able to write clearly. That used to be one of my problems, but good electronic patient records will put paid to that. But failure to make contemporaneous notes, things being added in later, and this sort of thing. Again, computer records have kind of put an end to that. But important to make your notes at the time of seeing the patient. Don't pop back 2 weeks later and add something in. But falling into bad record keeping habits. So we should all be auditing our own records on a regular basis, once a month. Audit your records or audit somebody else's records in the practice and let them audit yours to keep up with that. Failure to appropriately refer, so not referring in a timely manner, not understanding the level of urgency. All of these things, they always seem simple at the time. Failure to carry out the necessary clinical examinations, for example, visual fields or dilation, and we'll touch on that again this evening, and failure to correctly interpret additional information. So that's such an important thing. All retinal images that are taken in your practice should be assessed and signed off by the optometrist that's conducting the eye exam, the sight test. So make sure that you are seeing those images and signing them off yourself, not just ultra wide field, OCTs, retinal cameras, all of these things should be signed off by the attending optometrist. So record keeping deficiencies, illegibility, not directly an issue. Failure to record certain aspects of the exam. Note what tests you've done. Ensure they're recorded, even if they're normal. And consider adding certain aspects as to why you didn't do something. So symptoms didn't warrant eye steering or symptoms didn't warrant. So actually give your reasonings as to why you may not have done something. So the contemporaneous notes I've touched upon there as well. The simple answer to record keeping deficiency is quite simply just don't fall into bad habits. I've touched in the past in some of the lectures and at the conference on doing additional tests. So you remember I said about say retinoschisis versus a retinal detachment. A visual field would be immensely helpful to determining which of these two things you've got. So don't forget the additional test. Sometimes even a simple confrontation test for a visual field may be enough to give you extra information. Now, dilation is the controversial one because the gold standard has always been, if you're not sure of anything, dilate the patient. I think I've shown you evidence from research studies that say that the gold standard is now the ultra wide field imaging is non-inferior to the gold standard of dilation and Volk. So if you don't feel you need to dilate the patient, then you don't have to dilate the patient, but put the reasoning as to why you didn't dilate the patient. That's the simple answer there. But I will never tell anybody to dilate or not to dilate, but so often you gain nothing extra by putting the patient through the whole dilation system, but be sure you record your reasoning why you do or why you don't. And consider carefully what to put on the record card. So no further benefit considered available through dilation. better view obtained with ultra wide field imaging. And I put that one because some people become totally non-cooperative once you put stinging eye drops in their eyes. So sometimes it may be better not to do that. So think of the reasoning you're going to put on the record card. Cycloplegia doesn't really come there. But failure to correctly interpret additional information. Uh, so again, this thing of all retinal imaging should be assessed and signed off by the optometrist conducting the sight test. That shows you have viewed and you have considered the results of those images. And that is such an important thing to do that. Confirm the images have been viewed by you. An annotation can be really, really useful at this point because by putting your annotations on, it shows you've actually looked at the image because you had to be looking at it to put the annotations on there. Uh, and then in the patient records, you can put see annotations on image and give the reasonings within your records for your decisions. And this shows again you've analysed and interpreted the image so that you're satisfied with it. So things like image shows this, which is consistent with the patient's symptoms, therefore this is my conclusion. So that shows you've looked at the image there. And given the findings, I have advised the patient of the following. And provided that information is all within the patient records, none of the things that I brought up to date that could cause you to fall foul of GOC or college, none of that even enters the equation with you. So that's the really good news. So lots of images coming. What do I do next with these? You should already be able to look at some of these and say, oh, I think I know what's going on there. But because this is being recorded, I put this reminder slide up here of some of the changes that you can see at the different channels within an Optomap image. So for instance, we can look at a nevus at the top. You'll see it on the red channel, but you won't see it on the green channel. You might see some autofluorescent changes. There's drusen there. So remember what we've talked about in the past about what you're going to see at different channels and whether that will be helpful to you. So back to what we do simply when we're looking at the image there, when we're looking at whether there's potential pathology there, you've got to make decisions. So is the thing active, dormant, new, old, stable, unstable, benign, malignant? Is there an actual threat to the patient's sight? Is it associated with something that's systemic? All these questions you need to consider and answer. And then if you're going to refer, what's your urgency of referral and what's your reasoning behind the urgency of that referral? And if you're going to monitor, what's your monitor plan? Is this going to be days, months, or just a routine follow-up? And then we need to decide what information we're going to give to the patient. So that's what we're going to be doing this evening. But when you're doing all of this, consider what the patient's told you before in their symptoms and history. How long has, if they've noticed something, how long has that persisted? Hours, days, weeks, months? It's been there a long while, it's probably less of a problem. If it's acute, then there's more of a problem. Has it occurred before? So many times people talk about problems that actually turn out to be long-standing migraines. And if they'd asked if it happened before, oh yes, it's happened loads of times in the past. There's one missing off here, but I'll come to that in a moment. Is the vision affected? The type of onset? The area affected? Associated pain? And always the scale. If you've got a headache, how bad's that headache? On a scale of 1 to 10, where 1 is almost unnoticeable, 10 is can't get out of bed, where would you put your headache? So use numbers. We've talked in the past about flashes and floaters. There is one important one up there, which I have not put. Which eye? And a lot of people will write a referral letter saying this person has a cataract. And okay, whoever you refer it to, let's face it, they've got a 50-50 chance of getting it right. But it would help them tremendously if they know which eye you're talking about. No symptoms doesn't mean no pathology. A lot of changes and pathological changes you will see in the periphery with ultra-wide field imaging will not be asymptomatic. No symptoms may well suggest that what you're looking at is either old or dormant. So you may see something which has never been found before, but it may be old or dormant. But don't expect any pathology to always come with associated symptoms. So absence of symptoms can be a good guide that is something benign or inactive, but not always. So remember that. So with all those little pearls of wisdom, hopefully you've got lots of blank sheets of paper and a fully loaded pen. Here we go. This is case number 1. This is a routine eye test. You can see an image there. The patient is 78 years old. They have no symptoms. Their vision is stable and unchanged. Their general health is good. No medication, no flashes or floaters, no trauma reported. So, first question, and say, write these answers down as you go, and you can compare at the end. So, given that data, that information I've given you there, what does this suggest about the patient? Looking at that image, what does it suggest? Is the age relevant? So just think about what you're seeing there. The patient's 78 years old. Is what you're looking at, would you expect that with a patient like this? Is the age something that helps you in this decision? The answer is yes, it does. You would expect this sort of peripheral pigmentary change in a patient. So probably what we're dealing with here is a patient who, although the retina looks pretty horrible, actually that's not abnormal. I was with my 96-year-old dad today, and he's got very little hair and he's got a very wrinkled face. Doesn't bother me because he's 96. I would expect that sort of thing. My brother, who's only 70, he looks a bit like that, but then I'm not worried about him either because he's my brother. But there are things that you can look at and you say, that's normal. I'm not going to worry too much about that, even though it looks horrible. It's normal for his age. So what can you see on this image? So have a look at it. Bear in mind what I've told you in the past about how to analyze one of these images, and just write down what you can see on that image. So give you just a few moments to do that. There's a lot of stuff on there. So the sort of things that I'm expecting to see in terms of the odd things on there, we can see hard drusen. We can see reticular drusen. We can see pigmentary changes, and we can see atrophic areas. Now, what I'd like you to do at this stage, just give me a wave if you've got all of that written down. Okay, 1 or 2, that's good. If you haven't got that written down, as I say, at the end of this session, just go back and look at the image, because this is being recorded. As I say, go back and look at the image and see why you didn't spot it. We've got hard drusen, we've got reticular drusen, and we've got areas of dropout, atrophy there. I would hope you've also got the optic nerve head looks very washed out. That just happens to be an artifact. The macula looks normal and the blood vessels look pretty normal. So again, we're going to write down the normal things as well as the abnormal things. But what we've got here is mostly age related. So,
I mean, can I just interrupt for a second? Would that
yeah,
artifact with the optic disc just be because the patient is pseudophakic? Would we not get that in from the...
uh, that's because I'm using an early image
Oh,
where the
okay.
resolution was much lower. And also in order to highlight the drusen, which you all saw, I've had to brighten the image up a bit.
Yeah.
So, but as you look at that image, I would not blame you if you had written down that the optic nerve head was very bright or very pale or ill-defined, because that's what the image is showing you. Okay.
Brilliant. Thank you.
So, and then you can ask yourself the question, why does it look like that? And
Mhm.
then you can maybe adjust the software that you're analyzing with to see if it shows you anything a bit different from that. So again, here, chance to write something down. What I want you to do is write down your conclusions. So what we're doing here is saying, right, I've looked at that. This is what I reckon is going on, and this is what I think is normal or abnormal. What are your conclusions with this patient? And that's basically the conclusion. We've put down what we've seen, but the conclusion is this is normal age-related change. This is a normal condition, and therefore I don't need to do anything but monitor it routinely. And in this case, I'm going to monitor this person annually. So there's no desperate need to find something horribly wrong with the patient. It's what we expect from their age. And if your conclusion is written on the record card, it's normal for age. But you may also want to give, and again, let me know, give me a wave if you've written any of these down. You possibly want to give dietary advice, dietary supplement advice. If they're smoking, give stop smoking advice, and give home advice on lifestyle for home lighting and things like that. This patient is 78 years old. They're showing signs of age-related change. There are going to be problems to them visually in time. Maybe we should be looking at things like that. So I was with my 96-year-old father today. We were talking with a new care team. They were very, very pleased to see that we'd moved his lighting on his landing, so it was now over his stairwell, so he didn't fall down the stairs. They said they'd never seen that before. Then I told them I was an optometrist. So they're going to get their carers to check that out in every home they go into now. So advice like that, even with a patient where there's nothing wrong, can be immensely helpful. And again, if you add that to their record card, then that shows that not only have you analysed the image, you've understood what you're looking at there. And these are the sort of annotations that I would put on there. Now, as we go on, I'm going to give you a chance to put lots of other annotations on images, and you can put more on than I've got here. But this is relevant. We've seen the reticular drusen in the periphery. We've seen the areas of geographic atrophy. So this shows we've looked at it, we've understood what's there, but we've also pointed out the normal as well. So that's the sort of thing we're looking at to show there's an understanding there. So always annotate your images with your observations. So I'm going to give you a few moments now just to write down what you would put on the patient's record. How are you going to record this event on the patient record? Bearing in mind, I'm going to come in my cape with my lance and my scythe as the Grim Reaper, and I'm going to ask you questions as to why you've written down what you've written down. So just have a think about what you'd put on that record card. Okay, so again, see annotations on scan. Always a very good thing to put on if you've annotated your scan, because that will take whoever might be talking to you to see what you've put on the scan. Reticular drusen, normal for age. Not only have I said it's there, I've given an opinion that I would expect to see it there. Areas of geographic atrophy in the periphery. I've pointed out that I've seen them and where they are. The GA areas are consistent with autofluorescent findings. See autofluorescent scan. Now, I didn't show you the autofluorescent scan, but this is the sort of thing where if you've used other scans, you would add that to it. And then other things to put on your patient record, normal age-related changes. There's nothing wrong with this. Likely to be slow moving because there's nothing to suggest that it would be anything but slow moving. No signs of changes to the blood vessels. The vascular system looks good. It shows you've thought about that with the patient. And importantly, the macular region appears healthy. So again, if you give me a wave, if you got the majority of that sort of thing down there. And also, if you want to unmute yourself and just tell me what else you put on there, please feel free to do that as well. So if you've added something on there that you think really I should have put on there, do unmute yourself and shout out what you've got on there as well.
I cheated.
Fair enough.
Because you'd mentioned the dietary stuff and the lifestyle stuff and lighting, I'd put that in.
That's good. That's good. Because actually, you probably jumped ahead of me there in terms of the next question, which is what advice would you give to the patient and what would you record on the patient record card in terms of the advice you've given to them? So, so how are you going to tell the patient this and what are you going to put on the record card that you've told them? So another couple of moments just to write down what you're going to tell the patient. Okay, so this is the sort of thing again I would hope that you've got written down now. So you've advised the patient of the changes that are in the periphery of the retina, but you've also advised them that those changes are absolutely consistent with what you'd expect in a normal aging retina. So yes, it's there, but don't worry about it. It's normal. Uh, and then as we've already heard, advice given to the patient on lifestyle, maybe diet, weight management. Advise that there's no evidence that dietary supplements will benefit because we've not got any signs of macular degeneration in either eye. It's more about lifestyle and diet than it is about buying dietary supplements. Maybe advise the patient to self-monitor vision at home. And they don't need to have anything fancy for that. If they've got a picture frame they can look at and see if it goes distorted. Uh, the first time I noticed my father's macular degeneration was when he told me he was watching the snooker, and as the cue ball ran down the table, it jumped over a little lump and then carried on. That's how people spot things in normal everyday life. They don't need to necessarily look at Amsler charts and things. It's the silly little things. And then give the patient some guidance as to what they should do. So report back urgently if they see some obvious changes or anything like that. So if you suddenly do get a bleed in the macula or something, what you've done here is you've shown within the patient record that you've given them guidance as to how to react to a changing situation. That's great. Next appointment, 1 year or sooner, is what I would then put on there. So I've given guidance within the record card. Now, dilate or not dilate? Uh, Give me a wave if you dilate this patient. I have converts. That's good because then if you decide not to dilate, give your reasoning. So if anybody said to you, why on earth didn't you dilate this patient? Personally, I'd say because they were 78 and it wasn't worth the angst. But I've put here patient not dilated. The retinal changes can be seen clearly on this image. We're not going to gain anything from dilating the patient. And that's a perfectly acceptable thing to put on a record card. So what I'd like you to do, we're going to move on and look at some others now, but what I'd like you to do after this session is just look at the answers that appear up there now, compare them to what you've written down as we've gone through this, and then just see where you think you could improve your approach to somebody like this. And then as we move on to patient two, as I say, like Bhavina did, if you want to just unmute yourself and shout things at me, please feel free to do so, because this is always meant to be interactive as well. So here we go. This is a new patient, came to the practice, last seen 2 years ago, totally asymptomatic, female, 35 years old, good vision, general health good, no previous history, no family history, no medication. There is your image. So, what thoughts do you have at this point? Looking at the image, what thoughts do you have?
I would say a nevus that I've spotted.
Okay.
I'm just chiming in because you said
No,
unmute.
that's good. No, that's good. I've just gone quiet. So, okay. So it's categorically a nevus.
I'd like to see if it was
Hi.
there last time.
Yeah.
Simon,
So
because I went to the all day lecture, I'd say a grey blob with white spots on it.
wonderful. Wonderful. Yes. Good. Hey, I'm there.
That's only because I was there for the day, so I can remember what you said.
It just goes to show that a day can be long enough. So, yeah, at this stage, I'm quite happy. I mean, you know where I come from with this. It's a black blob until it's proven otherwise. But within that thinking of a black blob, the thoughts you could easily write down there is nevus, question mark, melanoma, question mark. The patient's got no other symptoms at all. So, you've got a blob there. It's a pigmented lesion. You know nothing else really at the moment. But looking at the symptoms and history, then it could be one of those things. It could be a chirpy. It could be anything at this stage. It could be any pigmented blob. But that's the point. At this stage, keep your mind wide open. But you've got a blob there, haven't you? And potentially it could be a nevus. So if you've written that down, that's good. So long as you've got a question mark after every potential diagnosis. So what do you see on the image? I think we've looked at that. Just again, write down what you see on that image. We had some good clues there. And then what might it be in the light of what we're looking at? Well, we've already discussed that. So what would you look for to help you differentiate your decisions as to what this might be? Again, just write down what would help you come to these decisions. And hopefully you've got looking at the red and green channels there. So you're looking at the different depths to see where this lesion may be occurring. And hopefully you've got written down there, looking to see if there's any deviation in the blood vessels across that lesion, to see whether there's any raising of the retinal surface. So if you've got any mass there, or is this just a thin lesion? So we're establishing whether we've got a real mass there or whether we've just got a pigmented area there. And those blood vessels will give you a big clue. Now, I haven't got the red and green images up here on purpose, but if you were analysing this, I would expect you to look at those and then again record what it is you have or haven't seen. So what's the significance of the white stuff? What could it be? And what could you do to help you decide?
Simon, you could do autofluorescence, and if it looks like snot, it's lipofuscin. And if it isn't snot-like, it's probably drusen.
I'm going to have to write a
It's drusen.
textbook. I really am. These are great descriptions. They're so memorable. Great. Yeah. And that's so hopefully you've all been writing that sort of thing down. Okay. If it's lipofuscin, it will fluoresce. If it's drusen, it may fluoresce, but it won't look that lovely description snot like. Okay, it won't look as if somebody sneezed all over the screen. So I think we've answered the question, what could it be? But again, hopefully, in answer to the question, what is the white stuff? Hopefully you've written down drusen question mark, lipofuscin question mark, because they're the two things that really it could be. And what could you do to help you decide? Well, Yes, autofluorescence, absolutely the right idea. What other procedures would help you decide on an outcome? So you're all going to write down one thing now, I know. So who hasn't written down OCT? So did you all write down OCT? If you answer OCT to most of these questions, you'll be right some of the time. So, okay, so what annotations are you going to put on this image? So you can just scribble yourself a little circle on your piece of paper if you like, with the nerve head, the blob, and just write on what you would put on there. And because some of you are very happy to unmute, let's see who wants to go first. Who's going to tell me the first annotation that they're going to put on there? So what's the first thing you want to point out on there with an annotation? Anybody want to say something? So what about nerve head? You could say there's a nerve head there, but what I've put on there, flat, pigmented lesion, well-defined margins, overlying drusen. That kind of explains what we've seen there. All right. And that shows anybody looking at your work. I've also put an arrow to make sure they know where I'm talking about. But that shows anybody looking at what I've been doing, they know I've looked at it. They know I've seen it. They know I've made certain decisions on it. I'm not saying what it is. I've made decisions. I've got a flat pigmented lesion. It's got well-defined margins. It's got overlying drusen. And the retinal vessels do not deviate across the lesion, evidence that it's flat. And again, it's on there. I've got peripheral pigmentary changes. Did anybody spot those? The honeycomb changes in the periphery? And did you write that down as well? And the retinal vasculature appears healthy, no hypertensive changes. So in this case, probably the honeycomb degeneration is normal age-related change, albeit the patient's relatively young. And I've put lid artifacts because I can, and it also shows I understand the machine. Give me a wave if you got all of those. And give me a wave if you're going to go away and review why you didn't get those. Excellent. Ah, good to see some waving going on there. Excellent. Anybody want to add any other annotations to that, which would be helpful?
Again, cheating, but based on your previous annotations, I just made a note that the macula, I was happy with the macula.
Yep, excellent. Again, it shows you've reviewed it and it's healthy. And it fits with what the patient's telling you as well. So there's nothing abnormal going on here. So what would be your clinical decision and why? So again, just write down what you think it is there and why you think it is what it is. So if somebody ever came in and looked at your patient records and say, what on earth did you call it that for? You've got reasonings.
Simon, wouldn't we need to have a look at the autofluorescence and the red-green first?
No, you don't, because I deliberately left those off. But I said to you that leave it that you can see it on the red, you can't see it on the green, and the AF's normal.
Okay, you can see it on the red, all right, but not the green. Okay.
Yeah. Yeah, I'm not being sneaky with this one. So again, it's a flat pigmented lesion. It's visible in the upper or temporal regional on the red channel, not the green. Therefore, it's a nevus. So I've said what I've seen. I've given the reasoning behind why I've come up with what it is. Okay. So if anybody said, well, why did you think it wasn't a chirpy? Well, it's because it wasn't visible on the green channel. So your reasoning's there all the time. You can answer anybody asking the question. I've also added drusen overlying suggests chronic, long-standing and stable. So that influences the way I'm going to deal with the patient, because I'm now happy from the evidence on that image that I've got a stable, normal, benign lesion here. And then mold score it as well. Okay. If you can mold score any of these on a patient's record card, this is an excellent thing to do nowadays, because again, it shows you've made a good analysis there. And what action, if any, would you take regarding the honeycomb degeneration in the periphery?
Systemic workup at the GPs, Simon, especially because she's only 35.
Yes, I think that's perfectly in order, because this is a bit earlier than you would expect. So these patients are at greater increased risk of stroke. Don't tell the patient that, because if they're at increased risk of stroke and you tell them that, they'll probably oblige. So how are you going to explain these findings to the patient? What are you going to say to them? I've given you one clue. Just don't write down you're at risk of stroke. So you've got all those findings there. Just note down what you're going to say to this patient. And I should be able to look at what you write down and tell you whether the patient was happy or not. So before I show you what I've got written down, does anybody want to come in here and just tell me at least one thing they would tell the patient?
I keep talking and I keep hoping that someone else will talk instead.
So they've got a flat pigmented lesion.
Yeah.
Okay. So you got something like a freckle or a mole. We've all got freckles and moles. They're normal. Don't worry about it. And so something nice and gentle to tell the patient, you're lucky. It could have been a melanoma. That's probably not the way of putting it. Okay. So, let them know that what they've got there is a variant of normal. Given its location and status, it's a common nevus. It's similar to a freckle on your skin. Hey, you're not perfect, but don't worry about it. Keep it so they're reassured all the time.
Simon, I tend to say, that 10% of people have freckles at the back of their eye, and that tends to calm them down, I find.
What you find a lot of patients think is, my God, that means 90% don't.
No, I think they find it reassuring generally, because they think, oh, wow, that's 10%. So
what you're looking at doing is saying anything that reassures them that, they're not perfect, but they are just a beautiful variation of normal. So you're looking to reassure them all the time. Patients tend to sit there and assume the worst if they possibly can. And so you have to say things that reassure them all the time. So, they've seen this image as well, and they're saying, well, what's this white stuff here? Oh, well, that's just a bit of waste product that shows it's been there for years. It's a good sign. So it's a good sign. It's not a problem. I'm glad to see that there. That's the sort of way you tell a patient. They're common, like freckles and moles on the skin. And I see loads of them each week. And I've got a couple on my retina, so they're not special. Or so you're not special. So reassure them that all the while it's normal. I bet quite a few of you have actually got at least one small nevus on your retina. So yeah, I got one too. We're in the same club. So all the while you're reassuring them that it's normal there, and we're just going to monitor it as we would anything else. So be reassuring and positive to the patient. That's the important thing there. Regard to the peripheral changes, these are very common in your age group, but may be associated with high blood pressure. So then say, have you had your blood pressure checked recently? and that preeclampsia you had a few years ago, you got over that now. It's basically say, right, well, if you'd like to have a blood pressure test, get one. It's a sensible thing to do in this day and age. So reassure them of that. Okay. So what advice are you going to give to the patient? So again, just write down what you're going to stick on this record card as advice, and think, if anybody asks me, are they ever likely to say, well, why didn't you say that, or why didn't you do that? So cover all bases here. Again, somebody just let me know what advice they're going to give to a patient. Let's try some of those. So they've got a nevus. They've got a lesion on the back of the retina. You're not going to tell them that it has a potential to turn malignant, but it does. If they were very fair-skinned, you might even suggest using sunscreen or a wide-brimmed hat. So why not talk to them about good UV practice? Protect the eyes from ultraviolet light. So good quality filter sunglasses. Explain why that's important, the way the UV light is focused by the lens onto the retina. So you need to minimize. So don't just say you need a pair of sunglasses, but explain to them why and how that will protect the retina and will protect them from any sort of unnecessary damage to their retina, not because they've got a nevus, but because it's just good practice. And again, putting that on the record card is so useful. And again, if you give advice to the patient, have a blood pressure and cholesterol check if they've not already done so. And again, anybody looking at the way you've treated that patient can see you've had a full understanding of the retinal condition and you've given them the correct advice.
Can I ask a question, Simon?
Yeah.
Would we ever want to email the patient a copy of their picture? Because if she's 35, and let's assume, well, no, and this is her first checkup at this practice, but she's had previous checkups by the sound of it, and they haven't mentioned this. And let's assume in 35 years, she's probably going to move around. So, people change locations. Should we be sending the patient a copy of their imaging so that they can take it with them should they move location? In the same way you have the NHS app, which now has things like your blood pressure that you can then move around.
Absolutely. I'm totally in favour of that. And I think the day will come when your patients will actually be able to download it onto their own records, or you will be able to do it directly one day, but they will be able to do it directly because they will have autonomy over their records on the app as well. So yes, and again, certainly within the Optos mechanism, you have a save button. If you press on save, you get the little drop-down box that says export, and you can just export that image in an email to them. And I used to talk about, you remember the 3-year-old with the nevus that I showed you earlier on? I would always, any retinal change in a child, I would always email that to the parent, because younger parents do tend to move around far more than older people. Grandparents tend to move around a lot to avoid the grandchildren, but you tend to find others move around because they've got a job to go to, and in fact, there's a lot of them in London, I've heard on the news today, are all going to move up to Manchester soon. So, these people are going to move. So yes, by all means, please do that. And actually, to say to the patient, look, you've actually got a nice looking pair of eyes here, couple of little changes from there. If you would like me to download you a copy so you've got it for your future reference, I'm very happy to do that. Your patient will love you forevermore for that. So that's the important thing there. And so, yeah, do send them images, no problem. And we talked about, didn't we, retinal tears and detachments, and how you should send that to the eye clinic and put it on the patient's phone. Same goes for things like that. So yeah, good point, good question. Thank you. So again, this is what we're going to put on the patient's record card here. So again, what you've seen and the way you've actually come to the conclusions that you come to with that patient, and the reassurance and explanation given, advice on light protection given. Peripheral changes may suggest vascular changes, patient advised to get. So again, you've advised the patient, you've put on the record that you've given them a course of action to undertake themselves. If they came back and said, well, you never told me that, you can say, yes, I did. There it is. And there are my contemporaneous notes. And we did advise you at the time. So again, you're helping the patient and you're making sure that you've done all the right things as well. And then monitor routinely, consistent with moles findings. A routine 2-year appointment is fine. So I've really based that around the nevus, not the other findings we found in the periphery. Great. Now here's we're moving on. We started a bit late, so this is my favourite one of the night. So this is a guy who came to me. He runs a yacht charter in the was in the Mediterranean, and when he's standing on the foredeck of his yacht, looking at the horizon, a couple of months ago, he became aware that. Have I put it on there? It's disappeared off there. He came aware of a kink in the horizon, a distortion as he looked at the horizon. And he's also having difficulty reading the charts with his right eye because the central vision appears distorted and the vision slightly blurred. So think about this guy. He runs a skippered yacht charter in the Mediterranean. His yacht is generally moored up in Croatia or Malta in a marina. Okay, so these are the images. This is the color image. That's the red channel. That's the green. And that's the autofluorescent. Just run you through those again. Color, red channel, green channel, autofluorescent. So that should now have given you a lot of information. So what are we seeing on this image? What is the image telling you at this stage? And what do the different images tell you? And what's the significance of the autofluorescent findings? So a whole series of questions there. So have a think about it. I'll just, whilst you're looking at those questions that you've got, hopefully you've got them written down there. I'll just run through the images again. So don't forget at this stage, we're not looking to diagnose this. We're looking to see what the image is telling us. And then we can come to some conclusions from there. So this guy's clearly got symptoms. Are those symptoms fitting with what you're looking at here? And if so, why? Why do you think they fit? And finally, on that one, are there any additional procedures that would help you decide an outcome? If you don't get that one by now. So, what have we actually got going on here? What can you see on here? You've got a series of lesions across the retina and also down here where you can see the choroidal vessels more clearly So the retina is clearly thinned out there. When we look at the red channel, you can see the choroidal vessels much more clearly through these spaces here. So clearly, this almost looks as if the retina has melted. And you can see that both this lesion and this lesion are encroaching very close to the macular region. So would they account for his symptoms? Give me a wave if you think they would account for his symptoms. So that's good, because it looks as if we found out why he's sort of the reason for what he's telling us. The fact he's got blurred vision, what else might that tell you, which comes up on here as well? Do the choroidal vessels around here look slightly blurred relative to the other choroidal vessels? So what does that tell us might be going on here?
Leakage.
Yeah.
Yeah, edema.
Edema, specifically. Yeah.
Mm.
And would edema fit with his symptoms?
Yes.
Yes.
Distortions and blurred vision? Yeah.
Yeah.
So what else might help us analyze this a bit further?
OCT.
The famous OCT.
I didn't hear the first time.
OCT.
Yeah, OCT will answer a multitude of questions here. So this guy is clearly having something going on whereby his retina seems to be literally melting. So how would you annotate these images? So within these annotations, you're going to share your thoughts, your thinking, your reasoning. So what are you going to put in little annotation boxes on this image? Here they come slowly. Numerous lesions across the retinal surface. Retina looks as if it's melted. Nothing technical, just stating the obvious. With a set of arrows pointing out the areas that I'm talking about. Absolutely describes what we're looking at there. If I was writing a referral letter because I didn't know what this was, that's how I would describe it. Underlying choroidal vessels seen clearer inside the lesion. Retina dissolved? Question mark? I don't know. But we can highlight why, what we've seen, and the thinking behind it. This looks as if the retina is melting. Lesion encroaching on macula probably accounts for horizon distortion and distortion of charts. So this is the lesion encroaching onto the macula. Retinal vessels undeviated across the lesions, so they appear flat. So we're annotating the image with what we're seeing, and we're saying, this is what we've seen, it's there, we've observed it. And then the autofluorescent one, numerous hypofluorescent lesions across the retina. Retina looks as if it's melted. Dark areas suggest atrophy. So again, you can actually fill this up with arrows if you wanted to, but we're pointing out the areas and why the patient's having problems with those areas. Apparent hyperfluorescence, probably inflammatory response or subretinal fluid in these central areas here. So again, we've given a reasoning behind the symptoms that are there. Hyperfluorescence in the lesion may be due to retinal thinning or underlying sclera showing through, so the thinning could be extensive. I'm not quite sure what's happened at the top there, but again, all the while I'm putting my thinking into the image so that anybody looking at that following on from me can look at my thinking as well? I don't know what's come across the screen there, but it's appearing permanently. I seem to be making
I'm going to
lines.
see if I can remove them. Hold on one second. Let me figure that out, Simon.
Yes, interesting. So putting annotations on the scan here is particularly useful because the amount of information and changes that are there. So adding your thinking here is good because it shows your active thought process is taking place. And again, it accounts for the horizon distortion. Your thinking is in there. So that's what you want. Now, the patient lives in a marina in a hot climate. So potentially, is this an acquired retinal disorder? Could that have come about through being in a marina? This is the sort of thing you want to put on the record card. The condition appears stable, but the hyperfluorescence suggests it may be ongoing inflammation. The changes adjacent to the macula gives a reasoning for the reported symptoms. And there are other lesions not seen by the patient, as the other eye has probably masked the effects. So the other important thing to note here, it's a monocular condition, so it suggests possibly a specific infection in that eye as opposed to something more broad. So I've given you another clue here. He's living in a subtropical climate on a boat in a marina, so he's not connected to mains facilities. Do you think that might have something to do with it? So again, when you're faced with a patient like this, you need to think broadly to see if you can understand what's going on with this patient. So what's the evidence you're going to base your findings on and your conclusions on? Well, the patient's monocular. They've got numerous lesions, possibly inflammatory responses. So could it be an active or a past uveitis? Could it be posterior uveitis inflaming? What might cause the uveitis? Is it viral, bacterial, biological? It's possibly associated to the hygiene of the environment. So does a climate factor add anything to your thinking? So what are you going to tell the patient and what are you going to record here? Now, bearing in mind, you probably don't know what this is at the moment. You can't really say to the patient, well, I haven't got a clue what's going on here. I'll see you in a year, see if it's got worse. This is not the approach to take. So you need to find a form of words as to what that image is showing you and what action you're going to take on this patient. So again, just write down what you think you're going to tell the patient at this stage and what you're going to record. So this is what I would do. So I found the lesion that seems to be causing your distorted horizon and probably causing your blurring vision as well. I'm not sure what's causing that, to be honest. I've not seen anything like this before, but you've got lots of these little things going on the retina. So it could well be some sort of inflammatory infection that you've got in that eye. And it's probably now dormant, but I can't be sure of that. Now, knowing the environment you live in, you're in a marina, you're not connected to the mains, you're in a hot climate, I just want to understand what's going on here. So I'm going to refer you so that we can understand what's really going on with your vision here and to try and establish a sort of a likely prognosis for you to see whether it's going to improve or if it's going to stay the way it is. So it's important we do that. I wish I could tell you more, but I don't know. So you're being open and honest with the patient about what you've seen and what's causing his problems. You can show him the image and say, this is causing your problems, but you're open and honest. I don't know what's causing this, so I'm going to refer you. So who would you refer this patient to? Who would, give me a wave time, who would refer to the GP? Who would refer to the eye clinic? Yeah, good. I think this is one for the eye clinic. The GP really not at this point in time. So in the first instance, I would refer it to the eye clinic because if there is an infection of some sort, it's important to establish what's going on as soon as possible and then instigate treatment to prevent any further visual deterioration. So get them where it matters. You know, the GP is liable to do their blood pressure and probably give them an anti-malarial for a few weeks. And if that doesn't work, send them to the eye clinic. So in the meantime, let's get on with getting it where it needs to be.
Simon, can I
So,
just ask? Can
yeah.
I just ask a question? You know, you've put probably now dormant. How would you know that it's probably dormant?
Because it doesn't seem to be worsening with the patient. And what I'm doing with, I mean, I've put that it's probably now dormant, hopefully, because on the autofluorescence, I've got no hyperfluorescence around those lesions. So it looks as if whatever's come has come and gone, and what's there is there, and you're stuck with it. So I'm not seeing anything active in the hyperfluorescence there. Possibly there's that hyperfluorescence in the center, which could be edema, but I'm not seeing anything that's really showing me there's any active pathology going on. So that's my personal opinion. That doesn't mean to say that's what you have to put. Please feel free to write me a bit of paper. Disagree with him on that one.
But what about the because there was edema, wasn't there?
Yeah, that's what I'm saying. I sort of basically I'm hoping that that's not active, but I don't know. I'm looking at the lesions, and the lesions look dark, so I'm thinking, well, whatever's happened there has happened. And you know, like with geographic atrophy, where you get the bright ring around the edge, suggesting you've still got ongoing activity. You haven't got that here, so it's probably what's happened has happened, and he's dormant. That was my thinking, and so that I would reassure the patient that was my view. I may have been wrong. So this was the outcome. It was monocular. It was actually caused by a protozoan getting into the eye and literally moving across the retina, and due to the secretions from that protozoan, it was melting the retina. So they actually found the little devil in the periphery. So he was actually referred to the School of Tropical Medicine, who treated him. So Hospital for Tropical Diseases, that's it. And he was treated there. And the likely root cause was contamination of water in the water tanks on his yacht. So when you think about it, if you go to a hot climate, like, I don't know, London in the last few weeks, you know, these hoses in a marina sit on the pontoon. And a lot of people just pick the hose up, stick it in their water tank and turn the tap on. So all that water that's been sitting in that hose for maybe 24 hours, it's got nice and warm and it's absolutely filled with bugs. And basically what had happened is because he didn't run that water off before filling the boat's water tanks, he contaminated his water tanks, drank the water, and Bob's your uncle. So, but that came as quite a surprise to me, to be honest. But they treated him with some, I forget what drugs they treated him with, but basically the condition was stable and effectively the damage had been done at that stage. But these patients come in, and this is where what you need to do when you see these images, as I said to you before, you don't need to know what everything is, but you need to be able to look at it understand it, write down what it is and what your thinking is behind what the image is telling you, and then going on from there to make your clinical decisions, and then justifying your decisions from the evidence you've got, and then adding that to the patient record. Okay. This guy now puts chlorine tablets in his water tanks every time he fills his tanks up now. So if ever you do charter a yacht in the Mediterranean, make sure that they've got chlorine tablets in their tanks. So, and there is another one on here, but I'm very much conscious of the time, and so I'm going to leave you that one along with your notes and everything, and the questions that are there, and I want you to work your way through that one. Okay. So we're going to do exactly the same with that. And then, as I say, look at the results that are on there. I don't know why I'm showing you the answers already, but just work your way through that one and see how you get on with that. Okay? All good? Happy with that? I think what I was saying is we'll stop the session now, but you can do this one sort of as homework, unless you want to carry on. If you want to carry on, then we'll carry on.
I'm happy to do as our participants want. Are we
If you
happy
want
to
me to go
carry
through
on?
this one, give me a wave if you want me to go through this one with you.
We've got waves.
We've got waves. Good, good. Okie dokie. Right, okay. So vision appears 63-year-old. Vision appears slightly changed at all distances. Feels he needs to update his glasses. Hypertensive. His condition is controlled with medication, but his medication compliance is poor. So there's his medication, there's his unaided vision, and there's his refraction. IOP, normal range. So apart from this yellow line that again has appeared, what can you see on this image?
Dot hemorrhages in the periphery. 2.
Yeah. Yeah. Would you expect that with a 63-year-old?
Possibly if his compliance is poor.
Yeah.
With his medication.
And again, it could just be vitreoretinal traction.
Yeah.
Snagging the capillaries. So again, you've got things that you need to understand whether that's likely to be pathological or physiological. But good, you've seen it, you've asked the question. So anything else in there that you can see?
I can see yellow deposits in the inferior part as well.
Yeah.
Possibly, well, I'm just naming, it could be some drusen or exudates, I'm not sure. They're very small though.
Yeah, good. Now look at his symptom. Look at his symptoms.
Has he got choroidal streaks in his macular area? They like choroidal, streaks.
Yes,
like horizontal
he's
streaks.
certainly got something going on across his macular region, hasn't he?
So it's like, I don't know.
Yeah, so
something going on there.
No doubt you've written down there choroidal streaks ? And streaks or lines across macula, but again, your theory could well be right at this stage. We need to work that out. So, and how do those observations explain that reasoning? I mean, if they were choroidal streaks, that's how they would appear, isn't it? So thin, horizontal, pale lines across the macula, horizontal lines like that, would be a sign for choroidal streaks. So makes sense. So at this point, what action would you undertake and why?
Do we have access to the the other versions?
You do. So that's the true color image.
Okay.
There's the green. And you can see those white dots much more clearly down there, can't you? Down at the bottom here, you were saying about earlier. But you can also see there's a lot more peripheral hemorrhages going on. So this is more likely to be something vascular than it is to just be PVD. So the fact there's numerous hemorrhages should alert you. There is the down at choroid level where you can see those streaks really clearly now. And there's the autofluorescence. What's interesting here, those streaks now appear slightly hypofluorescent, don't they? Which suggests there's actually thickening of the choroid, and so it's actually blocking the laser light at that point. So that's not true AF findings there, but it suggests that you've got some sort of folding of the choroid there at the same time. Your hemorrhages don't look so clear because you would expect that because they're up at retinal level. And you've got a few.
Yeah, I was going
Sorry?
to say, are they dysdrusen?
Yes. No, those aren't disc drusen because they're not on the disc, but they are drusen around the nerve head as well. So how does the observations affect your thinking? So I've got some streaky changes across the macular region. All images show it, so it's not an artifact. More clearly seen on the red channel, so maybe suggestive of choroidal folds. Possible obscuring of the nerve head margins. Is that idiopathic? Is there raised intracranial pressure? Is there acquired hyperopia there? So that's what the image is showing me, and that's what I'm thinking to myself, what's going on here? Has this patient suddenly become more long-sighted? That's more of a clue to me. So from what the image is showing me, I'm asking myself those questions. Okay. So the autofluorescence shows some hyperfluorescence around the nerve head, possibly radial in appearance. They may actually be angioid streaks. Again, that's not going to worry me if they are. And they do actually look typical of angioid streaks. But random temporal, small hemes, temporal, seen clearly on the green channel, so the hemorrhages are on the retinal surface. And there's some vessel crossing changes in the upper arcade, so there's possibly ongoing or new vascular changes. So this guy looks as if his hypertension is not stable at all. But I've not jumped to any conclusions here. I've just made some reasonings on what the image is showing me. And those are the sorts of notes that I would want to record for this patient. Question, have we got diabetic change there? Have we got hypertensive change there? Have we got PVD there? They're probably the three possibilities to causing those hemorrhages. So again, if you've not written any of that down, you need to revisit that and ask yourself, what is it I didn't see that led me to, or what is it about my thinking that didn't let me think wide enough to all the possibilities that were there? Okay. So if it's a PVD, there's no vice ring there, so it's likely to be partial PVD. But is PVD age appropriate for this person? It's kind of unlikely because of their age, but it should still be considered. So what annotations, last chance, what annotations are you going to add to your images here? Just think about what you would want to put on that image. Again, you're doing this to show somebody else that you've looked at that image and you've understood it. So what are the essential things you need to be highlighting on that image? There we go. So we've got the small peripheral dot hemorrhages, folds or buckling across the macular region, nerve head margins obscured. So I've asked the question on there, raised intracranial pressure. So I've not ignored it, and I've understood the severity of what might be going on there. So maybe we've got benign intracranial hypertension going on here. We've got an unstable hypertensive here. And I've highlighted the crossing changes that are alarming me as well. So all the things that could be causing concern, we've spotted. And then on the autofluorescent image, hyperfluorescent changes and radial changes, query angioid streaks. I may be wrong, but I've asked the question there. So what's the evidence you're going to base any referral on here? Sorry, not referral. What's the evidence you're going to base your decisions on? What is it you've seen on those images that you're going to use to come to a conclusion with? So let's have a look. So the patient's hyperopic. So there may be acquired hyperopia there. The folds across the macula are apparently asymptomatic, so the changes may be early. The nerve head margins are obscured, so that may suggest disc swelling. Folds can be associated with raised intracranial pressure, or they may be idiopathic. His medication compliance is poor, so maybe he's got unstable hypertension. That may cause vascular problems and intracranial problems as well. So ask myself the question, is it due to PVD? Are the hemes due to PVD? Or is it that the blood pressure is unstable? So I'm not seeing a vice ring, so PVD is either not complete or just not occurred at all. The autofluorescence suggests angioid streaks, but maybe therefore normal changes. So that's all the evidence I've got there. So what action am I going to take as a result of seeing those and asking those questions? So I've got a number of things that might be going on here. So what am I going to do, and what's my reasoning to back the action? So
Simon, wouldn't you do, like, because we don't really know if the disc is swollen, would we do OCT just
yes, you
to
could do that as
see,
well. Yeah.
just to have a look at the disc and sort of think, oh, is it
Whilst we're
swollen or is
doing
it
this
not?
patient, the fuse has gone in your OCT and you've had to call the engineer out. So literally on this one, just on the evidence you've got here, you've come to the conclusions from what that image has shown you, and you're absolutely right. The OCT is absolutely invaluable in this, which is why it's broken, because they always do that. So based on the evidence you've got, what action would you take, and what's your reasoning behind that action? So again, just note that down. Maybe go for a cup of tea till the engineer arrives. That may be the action you're going to take. But so I'm going to refer to the GP if for no other reason. I want a medication and compliance review, and I want that done quickly, because the changes suggest the possibility there is raised intracranial pressure, and we know his compliance is poor. So this is going to the doc as soon as I can get him there. And I would probably phone the medical team there and say, look, none of this nonsense about giving him an appointment in 2 weeks' time. He could be dead by then. I want him seen ASAP. And this is a doc one, at least for his medical compliance. I want his blood pressure checked, and I want a prompt referral to the eye clinic, because I want to understand what's causing those choroidal folds. They may be idiopathic, but there is an association with raised intracranial pressure again, and the nerve heads are obscured. So again, it could be raised intracranial pressure. This is a non-compliant hypertensive. So get him to the GP for medicines review, no matter what, but also get him to the eye clinic for investigation of the choroidal folds. And so that's the reasoning behind why I want them referred to where I want them. And mention in the referral association with raised intracranial pressure and the poor medication compliancy. It's really important to get this message across. And I wouldn't start haranguing these patients about how their medication compliance is poor, because if there are vascular problems going on that could be causing all sorts of secondary issues, we should not be winding this patient up any more than we really need to. And what do I record on the patient's record? Well, see annotations on scan. It's so useful to put your thoughts and annotations on there, and especially the note about raised intracranial pressure. It's important to record that you've registered that the patient is non-compliant with their medication. Any non-compliancy in medication is so important to record, because it shows you've taken due account of the fact that this patient could be doing themselves harm by being non-compliant. I suspect if ever you refer a patient who's had more problems with their glaucoma, who's not been using their drops properly, you would almost without thinking tell the eye clinic that they are non-compliant with their drops. It's the same with general systemic health as well. So again, all the things we've discussed, you should be putting on the record card as a matter of course to show that you've seen them and you've reacted to them. And the query of raised intracranial pressure is a very important one to put there, because it shows that you've taken due sort of notice of how serious this could be. Hyperfluorescent changes at the nerve head, query angioid streaks, peripheral blot hemorrhages, could be vitreoretinal traction or unstable hypertension. All these things, if ever you got asked by somebody querying what you've done with this patient, they looked at your record card, there is absolutely no way they can look at that and say you've ignored anything at all with this patient, and your findings that you've recorded on the record card are absolutely in accordance with what you did with the patient as well. And I've added at the bottom there, patient not dilated, the retinal changes were observed clearly with ultra-wide field imaging. There's no benefit gained from dilation. So you're just not going to get any more from that. So again, note it, so you can never be accused of being negligent through not dilating the patient, because you've shown you didn't need to. So again, written on the record card, given the possibility of raised intracranial pressure, referred promptly for GP for workup and patient advice, GP practice phoned, and prompt visit requested. So again, you've got to break down the wall of China, known as the receptionist, and get past them and say, this guy could be dead by 4 o'clock. You don't want that on your conscience. Be nice to them because they're NHS employees as well. So, but try and press the thing home, definitely. And request an eye clinic referral promptly to rule out raised intracranial pressure. So you've got to get across to the GP, the importance that this patient is seen and dealt with. And you've got to put this on the record card to make sure that anybody looking at it saw that you didn't take this patient lightly. And then if you do phone the practice, note on the record card you phoned the practice to advise the situation, request next day appointment, and you can log the time of the call and who you've spoken to. That's an important thing to do. So if they say, oh, you never phoned us, you say, well, I phoned you at 4:10 and I spoke to Maria. And so you've got the evidence there as well. And again, provided you do all of that, then you are absolutely covered yourself, but the patient has also received the best possible care that you can give them. And what do you tell the patient? Well, with these patients, you tread lightly. So again, point out the changes are probably benign based on the evidence and the percentage chance of raised ICP, but point out that their hypertension might be unstable. So some of the changes that are there could be due to the fact that their medication regime hasn't been followed properly. Show the patient the evidence of what you're referring them for, and make the patient aware of your need to refer and explain why. And you need to get it home to them so they don't decide to go home and then pack their suitcase and go on a 2-week holiday somewhere. They've got to grasp the seriousness of well. So reinforce the chances are low, but inform the patient that you're going to ask for a rapid appointment so it doesn't come as a shock to them. And again, stress the importance of them attending these appointments, and also take the opportunity to press home the importance of medication compliance. I've put that bottom line there, and I leave you with that sort of question when you've got a patient that is possibly facing something like raised intracranial pressure or even stroke or something like that. Is this the right time to say this may not have occurred if you'd taken your medication? I personally would not say something like that. When they come back and the incident is over, that is the time to say, well, none of that would have happened probably if you'd taken your medication, but this is not the time to put that on there. But record all aspects of this conversation on the patient record. That is really important, because these are the sorts of ones that can go pear-shaped very, very quickly. So that's it. So just summarizing that, ask yourself simple questions, look at the symptoms, ask yourself what's going on. What is that image telling you? The simple questions will give you the answers. And then if you decide to refer, look at the urgency of the referral. If you decide to monitor, then monitor and put on the record card at what interval and decide what information you need to give to the patient. But don't just monitor the patient for the sake of it. Ask yourself always, am I doing this just so as I save myself a litigation later, or am I doing it for the benefit of the patient? And there's no substitute for thorough analysis of the images, and then just draw your logical conclusions from what the images are showing you. So observation, consideration, deduction, conclusion, notation, explanation, information. And unfortunately, ok, duk, duk, ni is not a very good word to remember. So I couldn't think up a decent set of letters that would give you a nice word, but just go through that methodical process each time. Okay?
It is a case of repetition and making it muscle memory or mental memory almost, isn't it?
It is. It's absolutely that.
Yes.
And it just becomes, it feels as if you're going to need about 12 pages on every patient record card, but you're actually not. And you're putting the vital information down, and all that vital information is based on what the image is showing you. And as I say, if you remember I said at the start, when you look at that image, you don't need to know what it is you're looking at. You need to know what it's telling you and be able to write down what it's telling you and what logical conclusions can you draw from that. And if you see bits of retina that seem to have melted away around the macula and the patient saying their vision distorted, not a surprise, but you don't know what's caused it, but you put that into a referral letter saying it looks as if something has, literally it looks as if something's crawled across the retina. And you can put things like that and it will help people. So, and the fact it's monocular, not binocular, all these things that the images show you will help you with that analysis.
Yeah, brilliant.
Okay.
Thank you so much. Did anyone have any questions that they wanted to raise at this stage?
Lovely. I think you've all done very well because we extended that session tonight. But these are the important sessions because this is really about what you do with these images and how you go about the everyday sort of things in clinic. So I've kept secret what we're doing next time. I will pass that on to Bhavina so we can set up the August session and then we'll go from there. So it'll probably be snowing by August. So those of you who remember 1976, and probably most of you don't, September, October, November were just dire months because the weather broke in August and we had a terrible, terrible autumn. So on that joyous note, carry on enjoying the summer and I'll see you all in August.
Brilliant.
Thanks,
so much.
Simon. Thank you.
Okay, thank you very much. See you.